My name is Adam Gallegos. I'm a firefighter paramedic with the Castle Rock Fire and Rescue Department. Today we're going to be going over management of chest trauma. First off, we're going to ensure we have BSI on, gloves, eye protection. You can also verbalize this. First thing we want to do is administer high flow oxygen via a mask if they're conscious. If they need assistance, we can do it through a bag valve mask. We need to evaluate the patient for chest trauma. So first we're going to confirm the mechanism or the medical condition that caused the possibility of a pneumothorax. We're going to expose and inspect the neck, the anterior and posterior chest wall for any kind of respiratory compromise, whether it be tachypnea, accessory muscle use, asymmetrical chest rise and fall, or any open wounds. Should we find any open wounds, we're going to immediately cover it with a gloved hand and apply direct pressure. Then we're going to palpate the integrity of the chest wall, feeling for any subcutaneous air. Again, any asymmetrical chest rise and fall, any crepitus. Now we're going to auscultate for any unequal breath sounds, concentrating on the mid-axillary regions. And then lastly, we'll percuss. We're looking for hyperresonance, which would indicate air trapping, or hyporesonance, which would indicate any blood in the chest wall. So now we've established that this patient has an open chest wound, sucking chest wound, so we need to apply an occlusive dressing. First, we need to select our appropriate dressing. You can either use a commercial dressing, Vaseline gauze, or an Asherman chest seal, or you can use an improvised dressing such as a plastic bag, plastic wrap, or a bandage/gauze wrapper. So we're going to go ahead and wipe away any excess blood that we have. We're going to prep the site with either alcohol or iodine, so we've got it as sterile as possible. And then we're going to apply the dressing. We're going to immediately occlude it with a gloved hand, and if we have any uncontrolled bleeding, we want to go ahead and control that with direct pressure. Next, we're going to tape it on 3 sides. Allowing this to act like a flutter valve and allow air to escape. Now, if this should turn into a tension pneumothorax, we're going to go ahead and tape the 4th side and decompress with a needle. Now this patient's simple pneumothorax has progressed into a tension pneumothorax, and we've made the decision to decompress the patient's chest with a needle. First, we're going to locate our site that we're going to decompress on the affected side. There's 2 options here. We can go to the 2nd intercostal space, mid-clavicular, over the 3rd rib, or we can go to the 4th intercostal space, mid-axillary, over the 5th rib. First, we're going to prep the site using iodine or alcohol swabs to ensure a sterile environment, and we'll select our IV catheter that needs to be at least 2 inches long, and for this we've used a 14-gauge angiocath. We're also going to ensure that our flutter valve is prepared. Now it's time for us to insert our needle. I'm going to transition over to this simulated rib cage to perform the skill. I'm going to start with my needle resting against the top of the rib. I'm going to insert the needle using moderate force until resistance is met or I hear air escape. I'll advance the catheter while removing the needle, and I'll dispose of the needle in an appropriate sharps container. I'll secure the catheter using bulky dressings and tape, and then I'll attach my flutter valve. Next, we'll continue to monitor the patient and continue our transport. And this concludes management of chest trauma scenario.